So good morning, everyone. Good afternoon, good evening, everyone, and welcome to this new webinar. In my time, 9 p.m. in Geneva, we're just reaching the hour, so we will get going. But before I start, I would just like to acknowledge the unprecedented situation that we find ourselves in. Just 19 weeks ago, we knew nothing about COVID-19. Dr. Tedros, the Director General of the World Health Organization, acknowledged...
Good morning, everyone. For those of you just joining us, we'll start the call shortly, but please take a moment to use the chat function to update us all on your name, your institutional affiliation, country and professional background in the meantime. Thank you.
Disease. One that has affected all of our daily lives and realities, but we are all experiencing COVID-19 in different ways. So I'd like to thank particularly those of you that are taking time out of your work on the front line, working with patients, and also to express sorrow for those of you that may have lost loved ones in this difficult time. What we do know is that it's a solution of the cancer community, and we will have to find that solution in our own community. So it gives me great pleasure to welcome you today to this first brainstorming call of the Global Modelling Consortium on COVID-19 and cancer. It's great to see a lot of familiar names in the chat, and I encourage you to add your name, affiliation, and expertise in the chat as we get going to make sure we know exactly what skills you can bring to the table. We are expecting over 160 participants to this call, quite overwhelmed with the level of interest. So we have moved to a more formal structure, and please ask you for your understanding that we will put you all on mute for the first few presentations to just get through that first part. Please use the chat function to offer comments or post questions. If we do not get to them in the discussion period, do not worry, because we will have an ideas park and we'll save your ideas, and we will follow up with you individually after the call. So let me take us through the agenda for this evening. If you could take the next slide, please, Karen. So we'll start. Next slide, please, Karen. Oh, it's a bit slow. Right, okay. So we'll start with an introduction to the overarching COVID-19 and Cancer Task Force by Professor Richard Sullivan, Director of the Institute of Cancer Policy at King's College London, UK. We'll then move on to a deeper dive into the Global Modelling Consortium by Professor Karen Canfo. We'll speak to a couple of the confirmed partners of the consortium. First, IARC from Dr. Freddie Bray. The Canadian Partnership Against Cancer, presented by Rami Rahal, and then also the International Cancer Screening Network, presented by Associate Professor Arish Langsdorp-Fogelhaar. We'll hear from others about perspectives on linking activities to the work of the task force, talk about some funding opportunities and a future way for us to engage as a consortium, and then we'll open up to more questions and discussions. So without further ado, I'll pass it over to our first speaker. I'm assuming you're there, Richard. I haven't got a full list of people visible to me. Are you there, Richard? Can I hand over to you? Having a whiz through now. Okay, I don't see him in the list. Right. Okay, then I will present the slides on behalf of Richard. So, as I said before, we felt, some of us in discussions, that in order for cancer to be really taken into consideration in the response to COVID-19, we really needed to get the expertise from the cancer community together. And we formed this COVID-19 and Cancer Task Force. Next slide, please, Karen. This is a list of the task force members. You can see, if you gaze through that list, a good spread of geographical representation, different disciplines within the cancer community. And hopefully you'll see a few friends in that list. The slides will be shared, I think, on the webpage at the end of this session. Next slide, please. We've identified as a task force 3 prime areas for activity. We want to look at the direct risk of COVID-19 to cancer patients. We want to model the indirect impact, recovery and mitigation strategies. We also want to look at the direct impact on oncology health workers as the pandemic progresses. And we've also identified associated issues, research, particularly research that's going to be impacted by diversion of funds away to COVID-19, the ability to conduct research in the current environment, making sure we capture new practices, and we're talking a lot about silver linings, things we're doing because we have to, but might be good practice to take forward. We want to look at the economic impact assessments and particularly look at inequalities, because what we're already hearing reporting is that current known inequalities are being exacerbated by the COVID-19 pandemic. Next slide, please. We are pulling together all the current literature on one hub, hosted very kindly by eCancer, called the COVID-19 and Cancer Intelligence Hub. So we encourage you to write your own reports of experience that you're in your own centre or in your own institution. Please put those, share those reports with us. And if you find good papers in your own language or in your own region, please share it with us and we will add it to the hub. Okay, so I will hand over to Karen Kampfer to take us through the consortium. Thank you, Karen.
Thank you very much, Julie, and apologies for the confusion at the beginning, but we've sorted out the sound now. I just wanted to let you know that Richard Sullivan has been trying to dial in, so hopefully he will join us soon. So I wanted to give you an overview of the stream of work under the UICC Task Force, the COVID-19 and Cancer Global Modelling Consortium, or CCGMC as it's been provisionally called. So thank you very much for your expressions of interest. As of yesterday, we had 165 registrants representing 35 countries from 142 different organisations. And this map just gives you a little bit of a current snapshot of those that have expressed interest in the consortium, with good representation from North America, UK and Western Europe, Australia, and also representation from India, China, and parts of Africa. Obviously, we want to get the word out there, and we're currently still circulating information on all of our networks. So please feel free to continue forwarding the call for expressions of interest to any interested colleagues so that we can increase geographical representation. This slide shows a bit of a snapshot of the field of expertise. These are not mutually exclusive categories. So many of us come from epidemiology and public health backgrounds. We have almost 70 people who say that they are modelers of cancer screening, over 40 who model cancer treatment, over 40 clinicians, 40 policymakers, and a variety of other categories, including 15 infectious diseases modelers. So we're very happy that to date we've had a very good spread of these categories of expertise, as is required for this multidisciplinary endeavour. So we have summarised our themes in 3 parts, and this will correspond to 3 working groups that we propose to set up. So theme 1 is the direct impact of the infection on cancer outcomes and treatment services. Theme 2 is the impact on cancer screening and design of recovery strategies for screening programs. And theme 3 is the impact on cancer risk and, again, recovery and prevention strategies. And we envisage shared learnings and cross collaborations between these 3 working groups as we proceed. We've attempted to summarise the proposed governance and principles of engagement that we would like to encourage in the modelling consortium. As mentioned, the CCGMC will be one of 3 streams of activity under the banner of the Global Task Force, and it will both tap into and inform the other 2 streams of work on characterising impact on cancer treatment and psychosocial impacts. And in particular, we see an important cross-collaboration with the work being done on characterising impact in cancer treatment services in terms of data flow towards the modelling enterprise. So we will set up a steering group for the CCGMC, which will involve representatives of the overarching task force, the CCGMC partners, and the working group chairs. And we propose that each working group will appoint a chair or 2 co-chairs, and these chairs will represent the partners. If you do have any suggestions, please contact us because we're open to nominations for those roles. So we propose an open and collaborative approach with the key principles as follows: that we will share our learnings as we proceed, that for joint work that's progressed by the consortium, we will envisage co-publication, whilst recognising that many groups will bring in their own models and IP, and that needs to be recognised. We have a capacity building lens, particularly for trainee fellows, potentially from low and middle income countries, and for early career researchers globally. We are taking the longer term perspective as well as the short and intermediate term perspective. Although we can see the potential for some quick wins in what we can do, we think it's really important to say that we're not just here for the acute response. We're here to inform longer term planning and recovery, as we believe the impact on this crisis on cancer control will be enduring over the next 5 to 10 years. And we aim to develop tools that will be widely useful for policymakers in understanding the impact of the crisis and the optimum recovery strategies. We propose as we go forward that these principles will be captured in the terms of reference for all interested collaborators. We're also proposing to ask you all to follow standardised disclosure procedures and standard principles, and the Coordinating Centre will be in touch shortly after this call with a form to complete. Now, we are currently considering the approach for industry affiliates, and we'd like to see input here. At this point, we would propose potentially engaging such affiliates as observers. May I just ask you all to mute if you're not speaking, as I'm getting quite a lot of background noise. So this slide shows the proposed working group structure. So as mentioned, the overarching responsibility will be with a steering group, which represents the overarching task force and the partners in the consortium. And then we have our 3 working groups for cancer treatment, screening, and prevention. We propose that each of these 3 working groups will be able to tap into the expertise of 2 reference groups. One would be an infectious diseases modeler group, and the second would be a clinical expert reference group. And so here we propose that those of you on the line who are infectious diseases modelers, although you might be interested in active participation in one or more of the top line working groups here, we're very cognizant of the demands on you at present. And so what we propose is that we best harness your expertise by setting up an expert working group where you will be able to help us to inform modelling of future scenarios for infection rates as well as societal and health services disruptions in countries. In terms of the clinical expert reference group, we hope that those of you with clinical backgrounds on the call will be interested in joining and seeding this group. And all working groups are intended to access your expertise to inform the modelling of the impact of disruptions or changes in cancer treatment. Now, all groups will be also able to access facilities for ongoing scoping and systematic reviews of emergent clinical data on cancer outcomes, which will be performed by the Coordinating Centre, which is my institution at Cancer Council New South Wales. soon to be rechristened the Daffodil Centre at the University of Sydney. So we have defined a number of potential mechanisms of impact of the crisis on cancer outcomes, and this is just a broad illustration of those potential mechanisms. We all know from the top line that cancer treatment and services disruptions will have an impact, but we think there are a variety of other complex short and longer term mechanisms. If we think about the potential for decreased survival as a result of the crisis, there is in fact at least the potential for a direct biological impact on survival, if you like, due to the infection itself and the immunocompromise that it causes. Impact of treatment disruptions, effects on comorbid conditions, and we will need, of course, to take into account the competing mortality risk in cancer patients from infection as well. In terms of delayed diagnosis, of course, we've already seen in many countries significant disruptions to screening programs, and even those countries that haven't formally paused screening programs are experiencing declines in participation. We're also seeing delays in symptomatic presentation and disruptions to the usual pathways of diagnosis. In terms of longer term impact on cancer risk, there is the potential for a direct effect of viral infection on cancer risk. And of course, there's the longer term impacts of the already being well documented risky behaviours occurring due to the crisis itself, including its impacts on tobacco, alcohol, and physical activity behaviours. Now, the next slide just shows an illustrative result of the impact of delayed treatment of lung cancer from some preliminary modelling done by our team. And this just shows the age standardised mortality, in this case from lung cancer, for males and females projected from 1990 through to 2040. And you can see the status quo prior to the crisis in green, and the potential impact of disruptions on mortality over the next 20 years are indicated. And clearly those will be increased in the context of longer term treatment delays. So with that overview, I'd now like to hand over to our consortium partners to give their perspectives and talk about the links to their data collection and other activities. Thank you.
Hello, Karen. Hello, everyone. Can you hear me?
Yeah, we can, Freddie.
All right. Thank you very much. Thank you, Julie. So thanks, Julie. Thanks, Karen. I'm Freddie Bray. I'm the head of cancer surveillance at the International Agency for Research on Cancer. Just for those who do not know, I think it's great to see so many friends and collaborators on the call, and many will know IARC, but it's a specialised cancer agency of the World Health Organization. You will hear from our colleagues at WHO, Andre and Melanie, what they're doing in this space. So we're very much supporting their work as part of the World Health Organization. Our agency is interdisciplinary. It seeks to identify the causes of cancer so that preventative measures may be adopted and the burden of cancer is better understood and the suffering is reduced across organizations. So when Karen and Julie approached IARC and approached our director, Elizabeth Vidapas, I mean, it was really, we saw it as a great opportunity to help facilitate some of the research in the COVID and cancer space, not just in high-income countries, but low and middle-income countries, which is a feature of the agency and its partnerships and collaborations. So we look at causes and prevention of cancer. We're also a global reference point for cancer data and cancer statistics. We support population-based cancer registries. We are the umbrella organization for the International Association of Cancer Registries, and I think that the president, Joanne Aiken, is on this call, and we're providing evidence-based science global cancer policy. So within the perspectives of the agency, we've actually got quite a few people on the call who are experts already. I think they will probably speak for themselves, but people like Shama Varani, Jacopo Bassano, Billy Robbins, Philip Mayhew, Salvatore Baccarelli. These are experts in different domains of modelling and economics who can support this activity. But generally, very happy to be part of this. I mean, I think it's a real opportunity in New South Wales. Together with the other partners, we have a long-standing history of support for with the Canadian Partnership Against Cancer and the International Cancer Screening Network, and many of our colleagues at IARC are working as part of that network. From our perspective of the three themes that Karen mentioned, I think we can really support some of those activities, obviously through the cancer registry data. One thing we are doing with Joanne Aiken as the president of ICI is really trying to understand the impact of the COVID virus on cancer registry operations, because many registries have actually stopped their activities or curtailed them to some extent, particularly in low, medium income countries where registries have been shut, hospitals have been shut, staff have been seconded to other aspects linked to COVID, and the worry is getting the data that's missing for the months of when the COVID is linked to that. We've just sent a survey to all cancer registries around the world to identify the issues and what we can do to support. But as Karen has said, we're very much committed to working on these three themes: the modelling, the cancer outcomes, to see what happens to cancer patients who've acquired COVID. I think my colleagues who are on this call have specific expertise in screening and vaccination and lung cancer screening and cost effectiveness studies, so that there's a lot we can do collectively. But that's all I've got to say. So it's a very short message. I don't have any slides, obviously, but I've just filled from the international agency as part of WHO to be part of this, and we're looking forward to the collaboration. Back to you, Karen and Julie.
Thanks very much, Freddie. Rami Rahan, are you available to present?
I'm here. I'm here. Can you guys hear me?
Yes, we can.
Thank you very much. Excellent. Thanks. And good to be with you, colleagues. And I know we've worked with many of you at in current and previous engagements at CPAC. The Canadian Partnership Against Cancer is, as many of you know, works at the federal level. Canada is a federated system, and much of the responsibility for healthcare services lies with the provinces and territories. So our role at the Canadian Partnership Against Cancer is a convener role. We bring partners together. We act as catalysts and as propagators of the work in cancer control across the country. So on that front, we've been working closely with all of our provinces, who each have sort of taken on a different lead responsibility for some aspect of the COVID response and recovery effort across all three themes that Karen went over earlier. We're working with Ontario, for example, to develop some scenario planning and modeling around cancer surgery, and preparing the system to respond to the backlog and be able to absorb the significant number of unmet need for cancer surgery that has been accumulating over the last 2 months, in a way that allows the system to absorb the additional volumes and different scenarios for flexing capacity, both in OR and health human resources and allied health and other support services within the healthcare system. We are so to work to develop the model so that it's adaptable and responsive to the realities across the country of the different provinces and different considerations in the COVID current state. We're also working with British Columbia, who's taken the lead on developing some of the modeling around resumption of screening services, and that looks at everything from different scenarios for gradual resumption of screening, prioritization and stratification efforts, adjustments to thresholds for initial screening test results, the availability of downstream diagnostic services like colonoscopies and biopsies and colposcopies and so on, as well as obviously the mitigation of risk of infection associated with these thousands of screened patients potentially coming into the system to investigate abnormal results. We're also working, looking at different models of care within sort of, and virtual care being at the center of it in terms of how do we support different ways of delivering care to cancer patients that don't require them physically coming into the healthcare system, whether it's diagnostics or consults or follow-up, and looking at everything from the diagnostic to the palliative care side of things, and providing special training to paramedics who can deliver palliative care supports for patients in crisis at home and release and treat, as opposed to bring them into the ER and hospital system, and a bunch of other similar strategies. And on the issue, all of these models and approaches require access to real-time or at least near-time data, and that's an area that we've been working with our colleagues at the Canadian Institute for Health Information and the provincial cancer registries and health ministries to try and get more up-to-date data on utilization, so that we can actually look at what is going on in terms of surgical volumes, other hospitalizations, and be able to get more accurate trend analysis that helps feed into the modeling, but also helps us monitor the actual realities as we start to transition back to services. So a number of different areas, I think, where we can learn quite a bit from the work of our colleagues across the other countries, and where we're happy to share some of our experience in whatever ways are useful. So thank you, and that's all I have for now.
Thanks very much, Rami. I'll now hand over to Iris from the International Cancer Screening Network. Iris Lansdorp-Vogelbach.
Yes, thank you very much. I hope you can hear me okay.
We can, Iris, go ahead.
Perfect. So I'm very pleased to be representing the International Cancer Screening Network today. Very briefly, for those of you who may not know it, it is a consortium of countries, organizations, and experts around the world to try and reduce the global cancer burden by offering evidence-based cancer screening. And the mission is to promote evidence-based cancer screening implementations and research around the globe. And as you can see from the map here, it's very well represented across a large part of the world, although there's some underrepresentation, obviously, in Africa still. Next slide, please. Why is COVID so important for the International Cancer Screening Network? Well, as Karen already alluded to, many cancer screening programs across the world have actually been suspended because of the COVID crisis. This involves, for example, the USA, Canada, many countries in Europe, but also Hong Kong and New Zealand as other examples. And what you can see from the slide that I put in here, and this is not just screening, but there has been a huge impact because of the suspension of services on the number of cancers being diagnosed. This is data from Netherlands over the past weeks, and the first confirmed COVID case in the Netherlands was happening in around the green bar, and already then the numbers of cancer diagnoses started to decline. But especially when we saw the nationwide implementation of social distancing policies, the number of cancer diagnoses dropped by 25% overall. So this has really been impacting cancer in the Netherlands, and therefore also in the other countries across the world. The next slide, please. So what the International Cancer Screening Network wants to do is hold a survey among their network and ask questions on how countries make their decisions on what the delivery of screening and diagnostic services will be and how they decided to stop these and when, but also they want to query about what their plans are for resuming preventive health measures like screening. And we can use this information, for example, in this initiative as input for modeling, and hopefully the modeling can then formulate guidance for how to come out of this present pandemic with respect to cancer screening, and to inform decision-making on what the best strategies are to mitigate the effects of these delays in services. So what we hope to do in this consortium, next slide please, is that we would address theme 2, modeling the impact on cancer screening. And the potential questions that we could address is, of course, what is the long-term impact of suspension of the screening program, similar to what Karen showed before for lung cancer. We can look at these issues for stopping the screening programs for breast, cervical, and colorectal cancer for most countries, for some countries even lung cancer screening. And we can look at different ways of restarting the program and different ways of catching up with missed screening invitation, and look what the impact of all of these different strategies is. And this way we can hopefully identify the best strategy to restart the programs. And even if we look across all cancer sites, we could even think if there are some cancers that should be prioritized maybe over other cancer screening programs. So these are all things that we can look at. Our suggestion would be, as a theme, to initially work by cancer site, because we were very pleased to have more than 69 people involved from cancer screening modeling, but probably to make that workable, we probably need to divide up in smaller groups, initially working, for example, by cancer site, but of course having a lot of cross-fertilization across the sites. And later we can maybe put this work together and also have joint publication that includes multiple cancer sites. Next slide, please. I thought there was one more slide with an example. We already started, just to give you an idea, we already started a small initiative with 3 colorectal cancer screening modeling groups, which will look at some very basic, straightforward scenarios of the disruption and the end of disruption. And if you're interested in joining that colorectal cancer scenario, just let Karen or myself know, and then we can include you. Thank you.
Thanks very much for that, Iris. Also, if you're interested, you can add to the chat, because we will be monitoring the correspondence on the chat. Right, so just we're moving on now to look at perspectives from linked activities. So I think I saw Andre Ilbawi's name in the list of participants. Are you available to present, Andre?
So yes, just to start, greetings to colleagues and friends, and thanks to you, Julie, Richard, Karen, and the task force for the opportunity to share the current work we have at WHO and how this can align with the important work that this group is now leading forward. We appreciate the strong expression of interest and the commitment from each of you as a global sign of solidarity during these difficult and demanding times. I would also like to echo the recognition of those at the front line, caring for communities with COVID, and those that have been directly or indirectly affected by this pandemic. We'd like to share with you briefly the work that has been ongoing and planned at WHO, and as Freddie mentioned, in very close collaboration with IARC. As a start, and to reinforce that broad collaboration, please note the stakeholders that are listed as key collaborators in this work. Next slide, please, Karen. As a point of reference, we can start with the World Health Assembly resolution in 2017, in which governments endorsed cancer as a public health priority and request that WHO specifically develop a tool to support cancer control planning through costing and through priority setting. The intent was for a tool to be devised that was resource stratified or health system contextualized, one that could leverage the work of other organizations, as we've done thus far, and one that also identifies the most cost-effective interventions and can support national investment cases. Over the past 2 years, we've now been able to deliver on that and have developed a tool that can support governments achieve these targets. As you can see, some of the results were published in the WHO report on cancer released earlier this year, and we've been also able to successfully pilot this tool in select countries. It now includes over 200 different clinical and public health interventions and links to a database with more than 100,000 data points. But with this tool, we asked ourselves whether this could support COVID policy formulation. And as we started this exercise, we thought it's best to reflect on the context. What have governments asked WHO to provide and support? And do we have sufficient data in order to support governments in that decision-making process? Next slide. For us to now be able to deliver on the increasing number of governments who are explicitly asking for guidance on cancer in the COVID-19 pandemic, we thought the best approach is to do it through this stepwise delineation. First, we would take the exercise of defining what are the specific needs that governments are asking us to address and what platforms can be used, which is again why we appreciate this opportunity to collaborate with this task force. In this regard, I'd also like to ask Dr. Melanie Bertram, my colleague and the lead NCD economist at WHO, to comment on what WHO is doing across disease platforms to, in fact, better coordinate all COVID-19 related modeling. Mel, please, over to you.
Thanks, Andre. For those of you who don't know me, my name is Melanie Bertram. I'm a health economist and modeler at WHO, working in the Health Systems Department. Just want to echo Andre's appreciation for Karen, Julie, Richard, and the team for inviting us to be part of this discussion, and also appreciate everyone who is on the line very early or very late in their local time and taking the time out to be part of this global conversation. I know it's a difficult time for all of us. So I'm working within WHO as co-lead of an indirect modelling hub, where we're trying to work across all of the different disease modelling consortia to bring everyone together and work through some coherent, consistent modelling scenarios. So we've a number of advocacy modelling pieces going around talking about service disruption, and we'd really like to work better with the modelling community to come to a position where we have some really coherent service disruption scenarios to present to policymakers in low and middle income countries in particular, where they're struggling with their COVID response and with the continuation of essential services in the context of COVID. So we will be working across all the different disease areas, the HIV, TB, malaria vaccine modelling consortia, and hopefully this cancer modelling consortia as well, to work on normative guidance on how do models get used in the prioritisation process within the continuation of essential services during the COVID outbreak, and working on bringing together these scenarios from different disease areas to come up with an overarching comprehensive estimate of what is the indirect health impact of the COVID response. So we're hoping to work very closely with this consortium and bring you into the broader cross-disease consortium to ensure consistency and coherence in modelling methods across the disease areas. Thanks very much. Back to you, Andre.
Thanks, Mel. So as Mel is highlighting, it's both the model structure and also what data are being used to populate the model itself. In this regard, it's worthy to highlight the work that partners on this call have done. We've noted with appreciation the cancer and COVID registries that have been developed from partners such as ESMO, St. Jude, SIOP, and others who are gathering primary data that are absolutely essential to formulate and to structure both policy recommendations and a model. At the WHO side, we've also started gathering primary data through a government survey that was recently released, and we should receive the first run of data in the upcoming week or so as to what percentage of services have been disrupted, both within cancer and NCDs, and as Melanie mentioned, across other disease programs. Once we've been able to structure the necessary model and the requisite data points, the next step, of course, will be how can we address the specificities of COVID-19 using this updated model? And most critically, the final step of how can we ensure that the work that is done can support policymakers, program managers, and Ministry of Health officials to formulate those policies and programs to address both the current COVID pandemic and any other future cancer or other service disruption. Thank you both. Over to you.
Thanks so much, Andre and Melanie, and thank you for the nice little double act to keep us awake this evening in Europe. Are you available, Rocky?
Yes, can you hear me?
Very well, thanks, Rocky. Go ahead.
Okay, so thank you for the opportunity to speak. My name is Rocky Foyer. I'm one of the National Cancer Institute, U.S. National Cancer Institute project scientists for the Cancer Intervention and Surveillance Modeling Network, or CISNET. And as you may know, CISNET is a National Cancer Institute funded consortium of simulation modelers for breast, colorectal, cervical, lung, prostate, and esophageal cancers. It was formed in 2000, and the overall purpose is to provide a link between complex evidence and actionable public health strategies. And what's somewhat unique about CISNET is a comparative modeling approach where each cancer site group consists of between 3 and 6 independent modeling groups who work on central questions addressed by groups collaboratively with a common set of inputs and outputs. And reproducibility across models adds credibility to the results, and differences point out areas for further study in a very systematic way. Probably the most high-profile work has been assisting the U.S. Preventative Services Task Force in developing screening guidelines for breast, cervical, colorectal, and lung cancer, but the group's work has been worked in many different types of issues and areas. While CISNET historically has been mostly US-focused, more recently international work has been an increasing part of the CISNET work. Karen Canfield, who you heard from earlier, is a part of the CISNET cervical group, and Iris Lansdorp-Voglar is part of the colorectal, cervical, and esophageal groups. As part of CISNET, we want to be supportive of CISNET modelers participating in the global modeling consortia and COVID-related research. So to that end, we had a call last week with Karen. We included relevant NCI program directors and project scientists, representatives from NCI Center for Global Health, and the coordinating center PIs from the CISNET breast, cervical, and colorectal cancer groups. And since then, I've heard of that the CISNET lung group has expressed interest as well. And on that call, Karen gave us an overview briefing similar to one she provided today, and we discussed a potential funding opportunity for CISNET and others with active NCI grants to supplement their current grants to conduct COVID-related extensions of their work in areas very similar to the 3 themes mentioned today. And then finally, and perhaps most importantly, we discussed what scientific areas CISNET investigators might be interested in and how they could contribute to the larger efforts. I think folks were, excuse me. I think folks were mostly interested in theme 2, cancer screening, and more specifically, disruptions in cancer screening and diagnostic follow-up following positive screening tests, and then modeling the long-term sequelae of those disruptions on cancer mortality. Several NCI-sponsored consortia have collected data on delays in diagnostic follow-up in the pre-COVID era in different healthcare settings, which can serve, I think, as an effective baseline. In fact, in 2018, the CISNET breast, cervical, and colorectal groups used these data and published on the long-term mortality impact of these delays. We think that these same consortia can produce data during the COVID pandemic to allow us to get a handle on the magnitude of the drop-off in screening and diagnostic follow-up. I think CISNET investigators can help the overall consortium effort in several ways. First, the group has extensive experience in comparative and collaborative modeling. And while the efforts in this very large consortia might not be as closely coordinated as those conducted in CISNET, I feel our experiences could be helpful nevertheless. Secondly, we have experience, as probably many of you do, in trying to extrapolate modeling efforts from data-rich areas to areas where there's less of a data infrastructure in place to inform the models. Some of these experiences come from working at the US national level, for which there's extensive data, and extrapolating to the state level where there's less data. And another relevant experience comes from the efforts of the MISCAN group for the EUtopia project that's funded by the EU to use modeling to improve breast, colorectal, and cervical cancer screening in almost every country in Europe. Thanks for the opportunity to say a few words. and we're really looking forward to the progression of research in these important areas. Thank you.
Thank you so much, Rocky. I think we can definitely build on the experience from Sysmex. I'm hoping Richard has now joined us. Richard, would you like to comment on what we've heard thus far and maybe talk about the perspective of how we're going to be drawing on all of these experience across the task force as well as in this modelling consortium?
Super. Hello, Julie. Hello, everyone. Sorry about that. I'm afraid surgical incompetence with being able to use Zoom. Nice to join you all. Yes, thanks very much indeed. Maybe I'll just start with a few reflections really about the origins of the task force and a few areas that are ongoing at the moment. I think it's fair to say with part of the task force is trying to pull together the indirect impact of, the direct impact of COVID-19 on cancer patients. And there's been a very large adult database pulled together on the 83,000 plus deaths now with very high resolution data. And that's something I think is going to be coming out over the next few weeks. And it's quite interesting because we're only seeing an infection fatality rate of 0.3 to 0.4 with that group. So it's really reflecting age over 70 years old and comorbidities, very high levels of ACE27 grade 2, grade 3 comorbidities as the major risk factors there in that database. And Andre, I don't know whether you want to say something about the WHO Childhood Cancer Initiative with St. Jude's and PSYOP as well, because I know they're looking to collect worldwide data on the experience with children with cancer. So Andre, do you want to say anything about that?
Yeah, thanks, Richard. And perhaps the best would be to offer our colleagues. I know Nikhil is on the call, and I think also SAP is represented. But as you've noted, these databases will be absolutely critical to better understand how we will formulate the inputs of the model itself, how it's being done, how data are being gathered, and the update of the current registry itself. Perhaps, Nikhil, if you want to make a comment on that, please go ahead.
Yeah, no, thank you, Richard and Andre. I think, as you know, like most of the other groups, we're trying to collect as many cases as we can globally. We're also working in partnership to develop kind of a federated database as well. So over the coming weeks, we hope to provide that. And we're just trying to put up some of the visualizations online as we speak.
Brilliant. Thanks very much indeed. I should say one of the things that we did before this telecom is to have a look to see how many models were currently under submission to journals. And so far, we've got 43 different groups are under submission with various journals, from Lancet Oncology to New England Journal of Medicine, looking at national data sets with the delay in diagnosis, delay in treatment, and long-term impact on economics as well. So there's obviously a considerable amount of interest and activity out there around this modelling business and the modelling consortium. And finally, just to say as well, something for the group to think about is recovery and mitigation. And I think it would be remiss of me not to say that in a lot of countries, data is very scarce. And so we're going down a far more qualitative perspective. And I'm thinking particularly about partners here in Jordan, Pakistan, Zambia, Malawi, Kenya, and places like that, where a lot of the data in terms of the lockdown impacts, recovery and mitigation are essentially going to have to be gathered using qualitative methodologies. But it would be useful, I think, probably from a consortium perspective, think how we could potentially use surrogate markers as well to look at the impact of lockdowns and also the direct impact of C-19 on cancer services in those areas. But there's a lot more to do as well, particularly around the impact of shutting down research, the economic impact, particularly for out-of-pocket expenditures in various countries where that is a serious issue and will continue to be a serious issue that we need to take forward. But thank you very much indeed, Julie. That's all I have to say.
Thanks very much, Richard. Karen, are you able to take us through the next couple of slides and then open up for discussion?
Sure. Thank you, Julie. Thank you, Richard. So I just wanted to bring us home by just saying a few words about our thinking on funding streams and also to talk a little about next steps. So the consortium is initially being formed on a volunteer basis. The Coordinating Centre will provide initial secretariat support as well as expert scoping and systematic review support for the modelling enterprise. And clearly, as we've heard today, we expect and hope to be able to link into the other streams of work that you've heard about in terms of data sources. The consortium will aim to jointly seek funding opportunities, and I think this could be at many different levels, from small grants for fellowships right up to programmatic funding and everything in between. So what we're proposing to do is actually embark on a fairly systematic process of identifying funding opportunities worldwide, but it would be good to take the opportunity now to ask you to send in any that you know of. Please don't exclude country-specific opportunities, because we may be able to use those to help policymakers in your country with the appropriate funding. So the next steps, so each of the 3 working groups will form over the next week or 2, and we'll aim to hold a call for more detailed discussion within the next 2 to 3 weeks at the working group level. So in between times, the Coordinating Centre is going to follow up with a few items with you. Firstly, to confirm working group membership based on your expressions of interest at the point of registering. Please let us know if you want to change or extend your membership of working groups. Completion of disclosure forms. And we also want to move to do a bit of a more comprehensive audit of the model platforms that members are bringing in, and this will help in the initial working group discussions in thinking about configuring some of the comparative modelling exercises that Rocky and others have alluded to. We will draft an initial terms of reference for consideration within each working group and to be considered at our next whole group meeting. And we will provide the results of our initial scan of funding opportunities. And as I mentioned, please forward any suggestions to the Secretariat email, which is shown there. The Coordinating Centre will configure a website and a newsletter to keep you informed. And we propose that this overall consortium will have a follow-up call to update members on progress with a likely timing mid-June, in about 5 weeks' time. But we'll be running another doodle poll to find the best time, noting that this particular time isn't great for our Asian consortium members. So now I think we can open up to discussion, questions and perspectives. We recognise that we'll be able to probably only touch the surface of your thoughts and comments. But again, please use the chat box to note comments, and we'll be making sure to go through them later. So I'm going to hand back to Julie to moderate the questions. Thanks, Julie.
Okay, Karen, are we going to unmute everyone so people can just raise a hand if they want to speak for this part? Can we do that? I don't actually have any. Yeah, I don't actually have any questions in the chat box at the moment. So would someone like to raise their hand to ask a question? If you click on the participant section, you can actually raise your hand. I can show you how that happens. Can you see mine?
I can't see any raised hands, Julie.
Okay, so maybe that was a lot of information for newcomers in one go. Any questions from task force members on the call to get the conversation going?
I'm sorry, Julie, Rami has just raised his hand, so Rami has a question.
Hi, yes, I'm just wondering in terms of, I mean, there's obviously a lot of work to do, a lot of need for better data modeling analysis and shed light on. In terms of identifying priorities, so is that something that the working groups will be looking at? Because obviously there is a lot that we can do, and we have limited resources and time. So I'm assuming that's one of the first things that we'll be doing in the working groups.
Do you want to respond to that, Karen?
Yes, thanks, Rami. That's a great question. Yeah, we definitely see an important role for a clinical and policy reference group that we need to set up. And You know, I guess the important point to raise here is that we have, I know, a number of interested clinicians and policymakers online, and we would very much like you to form the nucleus of that reference group. But now, having heard a little bit about our thoughts for the consortium, I guess we would like you all to think of appropriate representatives that might not be on the call and forward in those suggestions so that we can set up wide engagement with policymakers in different countries. Of course, we are, able to tap into the broader expertise of the overall task force. So that will be an incredibly important reference point for the priority setting process through that steering group. Mm-hmm.
Sounds good. Thanks, Karen.
Great, thanks for that, Remy. I also see a raised hand from David B.
Oh, hi there. Nice to see one or two familiar faces there. I'm a respiratory physician from Nottingham in the UK and have a real, obviously, some experience on the front line of looking after COVID patients. One of the things that I wondered about was whether we should also be looking at the impact on non-cancer disease. And the only reason for that is that one's trying to think of positive aspects of this all the time. And one of the things that I was wondering about was whether the reduction in transmissible disease in general in a population that are at risk of other conditions like ischemic heart disease and exacerbations of COPD, particularly thinking of the lung cancer side, has any impact at all on the general health of the population or cause mortality, and therefore could even raise the profile of the importance of preventing cancer deaths, because of course that shouldn't be affected. And I wonder whether whilst everyone's modelling the impact on cancer and trying to tease out the sort of negative ascertainment bias with regards to just not diagnosing cancer because it never presents, particularly very aggressive cancers, versus the potential positive effects that one might get in other diseases. But it's just a sort of wild thought, but we didn't seem to discuss anything about non-cancer disease there.
Yeah, I'm happy to speak to that, and then I think Andre and Melanie from WHO would be able to add a good perspective here. Thanks, David. So look, I think that it is very important, as you've noted, for us to characterise the impact of the infection on potentially on comorbid conditions in cancer patients and as a competing risk for cancer. And so in that regard, we will be looking at those outcomes. We will have to look at those outcomes in some form. But I would say our primary aim remains to model the impact on cancer services and cancer diagnosis per se, rather than other outcomes or other NCDs. What we hope to do is to tap into some of the other networks that are already up and running. And as you heard from WHO, I think that there will be opportunities with their broader activities to tap into the impacts on other NCDs. Andre, would you like to comment on that?
Yeah, you summarized it well, Karen, recognizing the time. Just to reinforce your point that there will be a broader modeling consortium addressing the exact questions you raised, David. So we're pleased to also facilitate interval discussions with you and with others who may be interested in seeing how that work is progressing. And we've invited Karen also to be a key interlocutor in that process.
Thanks, Andre. So mindful of the time, I'm just scanning through to see if I can see any more flags, but Julie, I don't think we have any more questions at the moment.
Yeah, there's some positive comments on the last issue, which I think we can follow up on.
Great, thank you very much. Well, on my behalf, and if I may, on behalf of Julie, Richard, and the wider task force, and all the presenters and partners today, thank you very much for your attention. Thank you for making the effort to log in. We greatly appreciate your time. We hope that you will continue to be involved in the task force and in the Modelling Consortium's work. So please stay tuned. We'll be in touch, as we've noted, and we hope to interact with you through the working groups in the coming weeks. Thank you.
Thanks, Karen. Thanks, everyone.
Thanks, everybody. Bye-bye.
Thanks, everyone.
Thank you.
Bye-bye.
Bye-bye.